Great. So, good evening, everyone. My name is Rahul Sharma. I'm a neuro-ophthalmologist at the University of Toronto. And on behalf of the ACUPO chairs and my co-moderator, Dr. Edsel Ng, it's my privilege to be your host for the pathology session of the Canada-wide Update and Review lecture series sponsored by the Royal Alexandra Hospital Foundation and the University of Alberta in Edmonton. Our very esteemed ocular pathology speaker is Dr. James Farmer, who's one of the few physicians with dual board certification in ophthalmology and pathology. He completed his ophthalmology residency in Ottawa, a pediatric fellowship at Smith Kettlewell University of California, a pathology residency at the University of Vermont, followed by an anatomic pathology residency at the University of Ottawa. He's an associate professor at Queen's and an assistant professor in Ottawa, as well as the president of the Canadian Ophthalmic Pathology Society. He runs an excellent meeting at COS every year, and he's the editor for the pathology section of the CJO. So we're extremely fortunate to have Dr. Farmer here lecturing us tonight. I'll take it away, Dr. Farmer.
Well, thank you very much, Rahul, and Edsel for the wonderful introduction and the request to uh, come back and do the pathology review. As a PGY 47, I've been through a lot of this, so I relish in the ability to talk and quiz and everything, and always calls to mind. Some out there have heard this story a billion times, but when I was doing my residency in pathology and signing out with a pathologist who was in charge of the medical students, he asked me about how I would grade a short answer question from one of the students. And the short answer question was, name three constricting lesions of the colon. And the student had put down A, cancer, B, inflammatory bowel disease, and C, this exam, which is kind of the way I viewed the Royal College and all the other exams as well. So should be a good review for the ophthalmology residents heading towards the OCAPs and the Royal College, and I hope it will keep the other members who have already finished at different years of postgraduate training on the toes. So I have no financial disclosures, but I'm still looking. So what I'm doing is I'm going to give you the question. I'll give 5 seconds for people to cognate what they think the answer is, then we'll go through them. So question one, which of the following statements regarding this cytomorphology and retinoblastoma are accurate? A, this is associated with an older age at presentation. B, the genetic marker is MYC-N1 amplification. C, the tumor is typically hereditary. D, abundant rosette formation is typical. And the correct answer is genetic marker is MYC-N1 amplification. What one is seeing is a really high grade, more poorly differentiated type of tumor. We all know about retinoblastomas, the most common childhood intraocular malignancy. The origin is a retinal neuroblast, most likely a cone progenitor. The molecular biology is historic, and it was the first tumor suppressor gene described. The protein product is a tumor suppressor, requires biallelic loss to fail to suppress tumor formation. We're aware there's a hereditary where there's a germline mutation, so only one somatic allele needs to be lost. In the sporadic form, the somatic biallelic loss is required. But the new entry on the block is the MYC oncogene activation, which shows RB, the immunostain is positive, so it is not biallelic loss. It is a non-heritable form, early onset, usually 4 to 5 months. Usually presents peripherally, like on an MRI, unilateral, and it has a very aggressive course. So a patient with bilateral uveitis presents with this pathology. The most likely diagnosis is A, sarcoidosis, B, birdshot chorioretinitis, C, primary vitreoretinal lymphoma, D, sympathetic uveitis. This is an example of a diffuse granulomatous choroidal inflammation. You can see the retina here. This is an artifactual detachment, and one can see just a sea of blue and pink within the basically effacing the choroid. So birdshot chorioretinitis is an interesting entity well known to our uveitis specialists. Characteristic bilateral multifocal choroiditis, absent to moderate vitritis, retinal vascular leakage, minimal to absent anterior segment inflammation, more common in the 6 decades in women, Caucasians. There's an association with HLA-B29. but it is a non-granulomatous choroidal inflammation and vascular cuffing. Sympathetic, on the other hand, is a bilateral diffuse granulomatous T-cell mediated panuveitis. The etiology now is most commonly vitreoretinal surgery. Penetrating or perforating ocular trauma with or without uveal incarceration is the historic and still seen with this. The timing is 2 weeks to many years. One third occur within 3 months, and slightly less than half within a year. One sees this diffuse granulomatous inflammation, and this is a famous giant cell. If we see sparing of the choriocapillaris, we see epithelioid cells engulfing retinal pigment, sorry, not retinal, but uveal pigment, and then a Dalen Fuchs nodule is just a small granuloma underneath the retina. So a 25-year-old woman exhibits a solid white limbal nodule on the bulbar surface, and this is the pathology. What is the most common association? A, xeroderma pigmentosa, B, Muir-Torre syndrome, C, Goldenhar syndrome, or D, Gorlin syndrome. And the correct answer is Goldenhar syndrome. What we're looking at is a limbal dermoid. And you can see that this is basically epidermis with pilosebaceous units and a collagenous equivalent of dermis, but this shouldn't be on the conjunctiva. So this is also what we would call a choristoma. So just what Muir-Torre is, Muir-Torre is an autosomal dominant genodermatosis that is associated with benign and malignant tumors. It's a subtype of hereditary non-polyposis colorectal cancer syndrome, or Lynch syndrome, which is due to abnormalities in the DNA mismatch repair genes. In Muir-Torre and in Lynch, it's a germline mutation, so it requires one somatic mutation to lead to the microsatellite instability, which then promotes tumor formation. MLH1 is most common in Lynch. MSH2 is most common in Muir-Torre. Multiple sebaceous neoplasms, such as sebaceous adenoma and sebaceous carcinoma, but typically in the extraocular locations, such as anywhere else there might be abundance of sebaceous glands. We've seen it in the ear. It can be in the anogenital region. And the most important HNPCC related malignancy is colorectal carcinoma, which I've shown a picture. But the associations of dermoids and dermal lipomas important for ophthalmology is Goldenhar's, or oculoauriculovertebral syndrome. It has vertebral anomalies, these preauricular appendages, which are seen here, upper eyelid coloboma, and then a classic dermoid. The importance of recognizing this, especially in a small infant, is that 5 to 58% of Goldenhars are associated with cardiac abnormalities, such as a ventriculoseptal defect, tetralogy of Fallot, among others, which can be life-threatening. So seeing one of these should prompt a referral to a pediatric cardiologist. Epibulbar dermoids are also seen in the linear sebaceous nevus syndrome, which is this little stuck-on plaque, yellowish, on the forehead of this young child, also called Schimel-Penning syndrome, which has other neurologic correlates as part of the syndrome. So, what is the correct method for submitting tissue samples to achieve direct immunofluorescence for ocular cicatricial pemphigoid? Please choose one of the following. A, Michel's media, B, formalin, C, 70% alcohol, D, glutaraldehyde. And the correct answer is Michel's media. Michel's media is a transport media that can preserve tissue for anywhere from 5 to even up to 28 days, but it's best used within a week. And it contains ammonium sulfate and some uh, normal saline and a couple of other components. It doesn't fix the tissue, it just preserves it so that direct immunofluorescence can be done. So we'll just do a quick review. Ocular cicatricial pemphigoid is a subtype of mucous membrane pemphigoid, which is an autoimmune blistering and scarring disorder. It's directed against anti-basement membrane antigens BP120 and laminin 322. It can involve the oral, ocular, and other mucous membranes and skin. We are familiar with it as a bilateral asymmetric cicatrizing conjunctivitis that can lead to complete foreshortening of the fornices, entropion, and significant corneal issues. It is diagnosed by biopsy. It is preferable for the oculoplastic surgeons or external disease surgeons to submit two separate fragments. One goes in Michelle's media, and that is the one that is useful for diagnosis. And that's for the direct immunofluorescence, which I've pictured here. This is a nice linear staining of the basement membrane with IgG, and this is a nice linear staining of the basement membrane with IgA. It's useful to put a piece of tissue for in formalin so that we can correlate what the frozen section would show. We see the thickened acanthotic epithelium and this fibrotic dermis or fibrotic substantia propria. Sorry. Interestingly, we don't see blisters uniformly in the lesional tissue in the eye, unlike in biopsies from other sites where they try to get the actual bulla. So this should be taken as close to the symblepharon, but not on the symblepharon. A 10-year-old male presents with a mass located on the inferior tarsal plate of the left eye. The pathology reveals this. The most likely diagnosis is A. Conjunctival papilloma, B. Infantile hemangioma, C. Pyogenic granuloma, and D. Ocular surface squamous neoplasia. And the correct answer is pyogenic granuloma. Contrast that picture with what an infantile capillary hemangioma would look like. It's the most common periocular vascular tumor in infancy and childhood, more common in young girls. Its onset in the first 2 months postnatal, reaches a maximum size by 6 to 12 months, and regresses around the age of 5 to 6. It involved the skin and the subcutis of the head and neck 60% of the time, and anterior orbit is also involved about 90% of the time when present. It is a lobular growth of capillary vessels with an infiltrative growth pattern. Many of them don't seem to contain much of a lumen, but there's no cytologic atypia. The immunohistochemistry shows positivity for vascular markers CD34 and CD31, factor 8. But the most important one is GLUT1, which is the glucose transporter 1 protein, because this is specific for infantile capillary hemangioma as opposed to the other types of um, capillary hemangiomas that are not progressive in infants. GLUT1, interestingly, is shared by the fetal capillaries of the placental chorionic villi. And it's interesting that this tumor shows the same kind of evolution as the placenta does, where it starts small, grows big, and then involutes. And there is some evidence that the response to beta blockers is somehow tied through this GLUT1 receptor. Meanwhile, a pyogenic granuloma is the complete misnomer, but we carry it on anyways. At least ocular pathologists do. Anatomic pathologists recoil at the thought of using the term pyogenic granuloma because A, it's not pyogenic, there's no pus. B, it's not a granuloma. It's just it's a protuberant um, granulation tissue. It can be referred to as a lobular capillary hemangioma, but really it's a overgrowth of granulation tissue. You can see well demonstrated here the capillaries and then this inflamed stroma, some neutrophils, lymphocytes, plasma cells. The presence of this in a conjunctival biopsy is linked to which of the following abnormal test results? A, serum TSH, B, serum calcium, C, serum cortisol, D, serum potassium. And the correct answer is serum calcium. These are non-caseating granulomas, which are typical of sarcoidosis, but not diagnostic, pathognomonic of sarcoidosis. So sarcoidosis is a multisystem granulomatous disease of unknown etiology. We're very familiar with it in ophthalmology. It used to be if you knew sarcoidosis, you knew ophthalmology because it can involve every aspect of the adnexa right through to the optic nerve. The path are these discrete non-caseating granulomas. You can see the multinucleated giant cells when they rim the cytoplasm. They're called Langhans cells for interest's sake. They are not specific or pathognomonic for sarcoid. You would never, from a pathologist, render a diagnosis of sarcoidosis. We would say non-casein granulomas inflammation, and then you have to put it all together with the clinical picture. Interestingly, we're familiar with the elevated ACE, but back in the day, we used to use hand x-rays looking for bone changes, and elevated calcium to make a diagnosis of sarcoidosis. And the SED rate is also elevated. So a 65-year-old woman exhibits ulcerated yellow plaques on her forehead and left eyelids. This is the histopathological result from the biopsy. The most probable diagnosis based on these clinical and pathologic characteristics is A. Erdheim-Chester disease, B. Adult ocular xanthogranuloma, C. Necrobiotic xanthogranuloma, or D. Adult onset asthma and periocular xanthogranuloma. And the correct answer is necrobiotic xanthogranuloma. What we're looking in this photomicrograph here, a collection of inflammatory cells, lymphocytes, plasma cells, but these are multinucleated giant cells of the Teuton, T-O-U-T-O-N type, where the nuclei are internal and there's lipid surrounding them. They are characteristic of xanthogranulomatous inflammation. So what is adult xanthogranulomatous disease of the orbit and ocular adnexa? Presents with an eyelid or anterior orbital lesions, often with the appearance of xanthelasma-like lesions. There are four basic subtypes. Necrobiotic xanthogranuloma contains these indurated nodules and plaques that eventually ulcerate. The importance is 80% of these are associated with monoclonal gammopathy, such as the plasma cell dyscrasia, non-Hodgkin's lymphoma, plasmacytic lymphoma type. The second is Erdheim-Chester disease. Its disease tends to be more posterior in the orbit and diffuse, but it is a multi-system disease that is associated with abnormalities in the long bones, CNS, heart, lung, and retroperitoneum. It is associated with the BRAF mutations of the MAPK pathway, and this is also useful in its diagnosis and differential because the necrobiotic xanthogranuloma and the other ones tend to be BRAF negative. Adult onset asthma and periocular xanthogranuloma, as the name states, is associated with adult onset asthma, which may precede or follow the diagnosis. The rarest is just adult onset xanthogranuloma disease of the orbit. It's isolated preseptal and anterior orbital lesions. And again, the pathology characteristic is the xanthoma cells and Teuton giant cells. Excuse me. The presence of this inclusion within a plasma cell is more commonly associated with A. Malignant lymphoma, B. IgG4-related disease, C. Adult xanthogranuloma, D. Chlamydial conjunctivitis. And the correct answer is malignant lymphoma. What we are basically looking at is a Dutcher body, which is an intranuclear inclusion of cytoplasmic immunoglobulin. Plasma cells in general are terminally differentiated B lymphocytes. There are two major types of inclusions. We've just looked at the Dutcher body. The reason it is more commonly associated with neoplasia, as in lymphoma, is because it is a transformational change in the plasma cell. So it's almost like a dysplastic plasma cell. And MALT lymphomas being a lymphoma of precursor B cells, it's not unusual that those that would go on to any kind of maturation would show a transformational adaptation. The Russell body, which is seen here, which is just this very large cytoplasmic inclusion, is more typical of a chronic inflammation. Among the options listed, the most distinctive histopathologic characteristic of this lesion is A. Melanocytic hyperplasia, B. Squamous dysplasia, C. Elastotic degeneration, D. Reactive lymphoid hyperplasia.
A lot of C's in the chat.
Oh, question?
No, I just said there's a lot of C in the chat.
Oh, the correct answer is elastotic degeneration. What we've just looked at is a pterygium. The actinically induced conjunctival lesions that are benign are pingueculum and pterygium, and we're all familiar with this clinically. The pingueculum is the nodular lesion lesion of the bulbar conjunctiva, nasal or temporal in the interpalpebral fissure that doesn't encroach onto the cornea. And the pterygium, of course, is a flat wing-shaped fibrous plaque of bulbar conjunctiva extending onto the cornea. There is prominent elastotic degeneration, which is this grayish appearance to the uh, collagen in the substantia propria. It is so named because if you stain this with elastic stains, it stains positive. But if you digest the elastic stains, like use an elastase, where then the elastic would go, this still retains the elastic stain, whereas in a true elastic tissue, it would not stain. There's stromal hypervascularization and edema. The vascularity tends to be more marked in pterygium, and there is a fibrovascular invasion of superficial cornea preceded by a dissolution of Bowman's membrane, felt to be due to a localized stem cell deficiency induced by UV radiation. This tag of cornea helps to distinguish pathologically that this is unequivocally a pterygium. But many of the specimens we get in the lab don't contain a piece of cornea, so I tend to be more descriptive, even though it would fit with a pterygium clinically. A conjunctival biopsy of this lesion would be expected to be positive for A, SOX10, B, CD20, A, IgG, B, HPV. So in case people weren't paying attention before, but will be now, what this shows is conjunctival foreshortening, and it would be IgG. The SOX10 is a melanocytic marker, CD20 is a B cell marker, and HPV, we use a surrogate marker P16, which we look for when we're looking at ocular squamous surface neoplasia or conjunctival squamous intraepithelial neoplasia. The lesion indicated by the arrows showcases a specific feature of this tumor's growth. What does it signify? A, invasion through Bruch membrane. B, invasion through the internal limiting membrane. C, invasion through choriocapillaris basement membrane. D, invasion through Henle's fiber layer. And the correct answer is invasion through Bruch membrane. One can make an argument that the choriocapillaris basement membrane is a part of Bruch membrane, but specifically it is denoted in the literature as being an example of the mushroom configuration to a uveal melanoma created by invasion through Bruch's membrane, acts as a bit of a belt, if you will. All of the statements regarding this tumor in a 3-year-old boy depicted here are accurate, except A, the alveolar subtype is most common in older children. B, FOXO1 fusion positive tumors are associated with a better prognosis. C, the orbit is the commonest site in the ocular adnecta. D, for tumors confined to the orbit, combined radiation and chemotherapy show 95% 5-year survival. The correct answer is B. FOXO1 fusion positive tumors are associated with a worse prognosis in rhabdomyosarcoma. Rhabdomyosarcoma is the most frequent primary orbital malignancy in children. Typical onset occurs between ages 6 and 8. Most cases are found in children under 10. Embryonal is the most common. It occurs in the supranasal orbit typically, but also can occur in the eyelids, conjunctiva, where it forms a cambium type tumor, and sinuses. It's young children, and the pathology, most important, is fusion negative. It shows rhabdomyoblasts in a variable hypercellular pattern. but the fusion status helps determine prognosis in these tumors. The second in the orbit especially is alveolar, tends to occur in the inferior orbit, older children, and the pathology here is fusion positive. And the fusion partners are FOXO1 with either PAX3 or PAX7. But fusion positive tumors have a poorer prognosis compared to fusion negative or the embryonal. The reason it's important why when tissue is submitted, it needs to be submitted for molecular genetics is that some embryonal tumors can have a very alveolar look, which has a pattern like in the lung, and vice versa. And the prognosis is ultimately established not by immunohistochemistry into the subtype, but by the fusion status. And again, tumors localized to the orbit, there's an 89.7% 5-year relative survival rate with chemotherapy and radiotherapy. Okay, the endothelium from this DMEC is associated with which of the following positive immunohistochemical stains, excuse me. A, CD20, B, pancytokeratins, C, Merkel cell polyomavirus, D, Vimentin. And the correct answer is B, pancytokeratins. What we are looking at is a multi-layered endothelium, this multi-layering, larger nuclei, more cytoplasm, gives it an epithelial appearance. So it's an endothelium with an epithelial phenotype. We're talking in this circumstance about posterior polymorphous dystrophy. It's an autosomal dominant dystrophy. It's characterized by irregular blebs and vacuoles at the level of Descemet's membrane in the posterior cornea, surrounded by a grayish area of mild opacifications. Associations include corneal edema, glaucoma, and peripheral iridocorneal adhesions. The endothelium varies from atrophic to focally multi-layered and aggregated. And when we do immunostains, normal endothelium is cytokeratin negative. But in this circumstance, it shows cytokeratin positivity because it has this epithelial phenotype. Descemet's can be thickened, laminated with focal, nodular, and fusiform excrescences. There is one other condition in the differential of PPMD pathologically with this epithelial phenotype endothelium, and we'll talk about that a little bit later. Okay, an infant presents with bilateral corneal opacities at birth. This is the histopathology. Which of the following is associated with this condition? A, limbal dermoid, B, sensory neural deafness, C, cleft lip/palate, or D, posterior embryotoxin. And the correct answer is cleft lip and palate. What we're looking at is an example of Peters anomaly. Peters anomaly is the severe end of the anterior segment dysgenesis syndromes, sporadic inheritance with bilateral corneal opacities at birth, mutations in a number of genes, the PAX6 is the master regulator of the neural crest development in the cornea, PITX2, CYP1B1, or the FOXC1 genes. The associations are sclerocornea and cornea plana. It's also been described in fetal alcohol spectrum disorder. Peters plus is the association of Peters anomaly with cleft lip palate, short stature, abnormal ears, and mental retardation. It's more often seen in the bilateral cases. Pathology showed a concave defect in the posterior cornea with loss of Descemet's membrane, endothelium, and some of the posterior stroma with this edematous cornea over top. there are two types. Type 1 shows iridocorneal adhesions into the periphery of the defect. And then type 2, the crystalline lens is adherent or incarcerated in the defect, usually in the form of an anterior polar cataract. What is the unique pathologic finding in the blepharochalasis syndrome that aids in distinguishing this from other causes of eyelid edema? A, intralymphatic granulomas. B, abundance of Demodex organisms. C, IgA immunofluorescence around blood vessels, eccrine sweat glands, and elastic fibers. And D, amyloid deposition in the dermis. This is a good picture of the blepharochalasis in acute state. The correct answer is C, IgA immunofluorescence around blood vessels, equine sweat glands, and elastic fibers. Of course, the intralymphatic granulomas are characteristic of Melkerson-Rosenthal syndrome, which causes eyelid edema. Demodex overgrowth is a feature of Morbihan syndrome, which is related to ocular rosacea. And finally, amyloid wouldn't cause so much edema, but a full, somewhat discolored appearance to the eyelids or associated with uh, dermal hemorrhages because of the uh, tendency for amyloid to collect around blood vessels and make the blood vessels uh, bleed easily with trauma. So the blepharochalasis syndrome is rare. It occurs in childhood or early adolescence onset. It consists of exacerbation and remissions of painless upper and occasionally lower lid eye edema. The average duration of attack is about 2 days. It results in atrophic, wrinkled, and discolored skin. In the acute stage, one sees just massive edema with a cuffing of the blood vessels with a lymphoplasmacytic infiltrate, eventually going on to atrophy, fragmentation, and loss of elastic fibers, post-inflammatory hyperpigmentation, which is typified by a collection of melanophages in the dermis and associated with the lymphoplasmacytic infiltrate. And this is taken from one of the original articles describing it in the British Journal of Dermatology in 1996, which shows IgA direct immunofluorescence around blood vessels and then around eccrine sweat glands and elastic fibers in the dermis. The best immunostain to differentiate a poorly differentiated malignant medullopithelioma from a retinoblastoma is which of the following? A, pancytokeratin, B, S100, C, Pax8, and D, neurofilament. And the correct answer is Pax8. Pax8 has been shown in a paper from Millman and Eagle in Philadelphia when they were, and Dr. Uh, Hardy Mudhar in England, when they were looking at Pax8 in a case of a metastatic tumor to the choroid, wondering about a renal cell carcinoma, for example, and they found that a number of tissues in the eye stained positively with Pax8, which is a paired homeobox protein involved in transcription. And they found that Pax8 stained the ciliary body epithelium, iris epithelium, corneal endothelium, but it didn't stain uveal melanocytes or the retinal pigment epithelium. So they then stained their medullopitheliomas and their uveal melanomas and found it was a very specific marker for differentiating a poorly differentiated retinoblastoma, for example, which would be Pax8 negative, or a poorly differentiated uveal melanoma, which would be Pax8 negative, and a medullopithelioma, which arises from the non-pigmented ciliary epithelium, is positive. So Pax8. Neurofilament would be not useful in this case. Both would show some neurofilament positivity. S100 is a melanocytic neurocrest marker, and neither would be so pancytokeratin positivity in any degree, maybe a little bit of medullopithelioma. A 23-year-old patient had a persistent corneal ulcer that necessitated penetrating keratoplasty. The pathology of the cornea is illustrated in the accompanying photomicrograph. Which of the following statements regarding this condition are accurate? A, the dormant form is a single-walled cyst. B, keratoneuritis with perineural infiltrates are pathognomonic of this organism. C, this infection typically requires a month of multiple drug treatment. D, PCR has been shown to have a higher sensitivity for diagnosis than corneal culture. And the correct answer is PCR has been shown to have a higher sensitivity for diagnosis than corneal culture. And of course, we're looking at acanthamoeba keratitis. We are all very familiar with this uh, as a painful cornea out of keeping with the initial slit lamp findings. It's 90% are occurring in contact lens wearers. It's notorious for a radial keratoneuritis, but this is also seen in Pseudomonas keratitis, so it's not pathognomonic, and the ring infiltrate comes late. There are two subtypes, Castellani and polyphagia. The diagnosis used to be made with using a culture non-nutrient blood agar layered with E. coli, but PCR now has been shown to have a higher sensitivity than culture, and in most institutions I'm aware of is the go-to for diagnosis. I usually only see them when the cornea has been transplanted because of recalcitrant disease. It requires multi-drug therapy, and the recommended duration is 6 to 12 months of treatment in most cases. The trophozoite looks more like a macrophage, so it's a little harder to discern in tissue culture, but it's the double-walled cyst, the exocyst and the endocyst, which are characteristic on the histopathology. A 14-year-old girl presents with this finding. The most likely etiology is A, juvenile idiopathic arthritis, B, sarcoidosis, C, hypoparathyroidism, D, epithelial basement membrane dystrophy. The correct answer is juvenile idiopathic arthritis. And what we are looking for in particular is this band of a darker purple coloration just below the epithelium, basically within Bowman's layer, which is calcium. So band keratopathy occupies the central zone of the cornea. The etiology are chronically inflamed or traumatized eyes. Chronic uveitis, especially juvenile idiopathic arthritis, is a very common cause, and we see it in the end-stage Thesical eyes. It can also be seen following intravitreal therapy with silicone oil. It is also associated with systemic hypercalcemic states, such as hyperparathyroidism and chronic renal failure. The most likely etiology for this finding in a DSEC specimen is A, Fuchs endothelial dystrophy, B, Chandler syndrome, C, pseudophakic bullous keratopathy, or D, keratoconus. And the correct answer is pseudophakic bullous keratopathy. What we basically see in this DSEC specimen is a relatively uniformly thin Decimase membrane, maybe slightly bit of adherent Dua's layer, but there's no endothelium to be seen, and there are no guttae. So this is a classic finding of pseudophakic bullous keratopathy. This smear of a vitreous aspirate, this is a smear of a vitreous aspirate from a 66-year-old woman with chronic uveitis. Which of the following statements are accurate? A, she has a 10% likelihood of developing CNS disease. B, an interleukin 10/6 ratio of less than 1 is diagnostic for this condition. C, CK20 is positive in the neoplastic cells. Or D, MYD88 mutations are typical of this condition. And the correct answer is MYD88 mutations are typical of this condition. Of course, we're talking about primary vitreoretinal large B-cell lymphoma. It is a subset of primary CNS lymphoma. The majority are diffuse large B-cell lymphomas, ergo the name. 60 to 80% are bilateral. When presenting in the eye, if CNS lymphoma is not present at the time, 65 to 90% will progress to CNS lymphoma. It presents as a vitritis, which is the chronic uveitis pattern we encounter in clinic, and or a creamy yellow subretinal infiltrates with overlying, excuse me, RPE detachments. Pathology consists of these large, atypical B lymphocytes in a subretinal, sub-RPE space. The cells, because their B cells are CD20 positive, not CK20 positive, the interleukin 10 interleukin 6 ratio should be greater than 1 in this lymphoma. PCR for the MYD88L256P mutation is now characteristic of these large cell lymphomas and can be very helpful diagnostically, both on a vitreous aspirate or can also be done, recently reported by Vic Elner and a group from Michigan, and an AC tap in these cases. And then one always should include flow cytometry to prove the monoclonal nature of the proliferation. This finding in a case of painful visual loss is associated with which of the following conditions? A, acanthamoeba keratitis. B, Down syndrome. C, acute angle closure glaucoma. D, Posner-Schlossman syndrome. And the correct answer is Down syndrome. What we're looking at is a penetrating keratoplasty specimen of hydrops. You can see the rupture of Descemet's membrane and the scrolling of the membrane on either side, and then the central massive edema. Again, due to eye rubbing in a situation of keratoconus, for example, but this is the pathology of hydrops. Next, the most frequent mode of inheritance for this condition is A, sporadic, B, autosomal dominant, C, sex-linked, D, autosomal recessive. And the arrowheads are a guide to what you should be looking for. And the correct answer is sporadic. This is an example of epithelial basement membrane dystrophy, where there is intraepithelial accumulations of abnormal basement membrane material, forming either maps, dots, or fingerprints in a clinical appearance. And it most commonly is sporadic, although there have been reports of different modes of transmission, such as autosomal dominant. The presentation is often recurrent erosions. We're familiar with this in people who have recurrent erosion syndrome as well. MAPs are intraepithelial, multilamellar basement membrane material, filling in the epithelium. Fingerprint lines are rib-like intraepithelial extensions of basement membrane material, and dots are intraepithelial, pseudocysts. And these are all PAS stains, which highlight this abnormal basement membrane material. The histochemical stain displayed here is A, colloidal iron, B, Congo red, C, Massone trichrome, D, PAS. And the correct answer is Massone trichrome, as it has sort of a pinkish red and blue stain. This in particular is granular corneal dystrophy, important for the residents to know this for the exams. These hyaline deposition of the abnormal keratoepithelium in granular corneal dystrophy stains positively with Massone trichrome. And always remember, because it's trichrome, it's going to have a blue collagenous matrix. The nuclei are kind of a darker blue, and the epithelium has got a lighter pink configuration. More on corneal dystrophies. The method employed to generate the image on the left, which is the brighter one, from the image on the right is referred to, now if I was generating this, it would be opposite, but this is the this is the starting, and this is something done to it to give this appearance. Is this called A, color illumination, B, polarization microscopy, C, fluorescent microscopy, or D, confocal microscopy? The correct answer is polarization microscopy. This is a case of lattice corneal dystrophy. This is amyloid using a Congo red stain. The Congo red stains amyloid an orange color. When the polarizer is introduced to change the orientation of the light rays, you get an apple green dichroism and this bright birefringence as a property of the polarization microscopy. This corneal sample is taken from a patient diagnosed with Hurler syndrome. The intracellular site where the glycosaminoglycan accumulates is A, lysosome, B, cytoplasm, C, Golgi apparatus, D, nucleus. And the correct answer is lysosome, because Hurler's is one of the mucopolysaccharide doses, which is a lysosomal storage disease. Hurler's is one of the variants that contains this, and it would stain similar to a case of macular corneal dystrophy. But when you get down to the electron microscopic level, you see that the glycosaminoglycan in Hurler's accumulates in the lysosomes. Okay, this lesion appears as a yellowish tumor located on the caruncle. What is the diagnosis? A, nevus, B, xanthogranuloma, C, papilloma, or D, oncocytoma? And the correct answer is oncocytoma. The commonest tumors of the caruncle are nevi, then papillomas, and then oncocytomas, presenting as a tan to red vascularized mass, more commonly seen in elderly women. And the characteristic are these large cells with granular eosinophilic cytoplasm, which are degenerated mitochondria. They're called oncocytes. And importantly, they're frequently cystic. And this does tend at times to throw off non-ocular pathologists who are looking at these things. I've even seen one called a syringocystadenoma papilliferum, with somebody who's not familiar with them occurring in this location because they can be quite cystic. And it still does not detract from the fact that they are benign oncocytomas. Although there is a malignant counterpart of an oncocytoma, benign one, called a malignant oncocytic adenocarcinoma. I've seen two, one in a 43-year-old, one in a 75-year-old, highly aggressive tumors with a tendency to metastasize early and very poor prognosis. The most probable causative agent identified in this gram-stained capsular remnant associated with chronic endophthalmitis is A. Methicillin-resistant Staph aureus, B. Cutibacterium acnes, C. Strep pneumoniae, D. Bacillus cereus. And the correct answer is Cutibacterium acnes. This is a example of used to be called Propionibacterium acnes, but it has been since renamed Cutibacterium acnes, where it shows as a chronic smoldering endophthalmitis months to years after the original surgery. And it tends to be an indolent type infection, but just never really clears. When we get the capsular remnants to um, alleviate the issue, we stain it, we see these gram-positive coccal organisms consistent with Cutibacterium acnes. Staph epidermidis can also be a cause of this, but not strep pneumonia, virulent, Bacillus cereus, completely virulent, as is Staph aureus. All of the following statements concerning the lesion in the photo are true except A, usually seen in young males. B, typically presents bilaterally. C, low incidence of vitreous hemorrhages. D, earliest stages include retinal telangiectasia. And the correct answer is typically presents bilaterally. What we are looking at is an example of Coats disease. 95% are unilateral and typically occur in young males. Interestingly, if this occurs in females and you should rule out bilaterality and with a smaller instance in one eye, and the occurrence of facioscapulohumeral dystrophy in young girls. This is the Shields classification of Coats disease. Stage 1 is telangiectasia only. Stage 2 is telangiectasia and exudation. There's A is extrafoveal exudation, B is foveal exudation, then exudative retinal detachment, either subtotal or total. Total retinal detachment in glaucoma, stage 4, and advanced end-stage disease. What one sees are these telangiectatic retinal vessels, this characteristic subneural retinal exudate, containing foamy macrophages and these cholesterol crystals, which are the broken down um, residual cell membranes of the red blood cells. So this is a very classic example of Coats disease. So which of the following statements regarding the disease characterized by this histopathology in an endothelial keratoplasty specimen are accurate or is accurate? A, occurs exclusively in adults. B, collagen 7 serves as the main structural element of Descemet's membrane. C, variants in the TC4 gene are the most frequent cause. D, Rho kinase or ROCK inhibitors have not demonstrated effectiveness in repopulating endothelial cells in culture. The correct answer is variations in the TC4 gene are the most frequent cause of Fuchs endothelial dystrophy. It's the leading cause of corneal transplantation in the developed world, autosomal dominant with variable penetrance. There is a bimodal age distribution, early onset in the first decade. The late onset, fifth decade or greater, is much more common and is more common in women. Type 8 collagen is the principal structural component of Descemet's membrane. Transcription factor 4 variants form the most frequent cause of Fuchs endothelial dystrophy, and hope is on the horizon that ROCK or Rho kinase inhibitors increase cell adhesion to posterior cornea and promoted in vitro proliferation of corneal endothelial cells. So it does hold promise as a possible early treatment. The immune response identified in this situation, this pathological photograph here, is classified as A type 1, B type 2, C type 3, or D type 4 immune reaction. Of course, what we're looking at is phacoantigenic uveitis, which is a granulomatous inflammatory response to native lens protein that has been disrupted through trauma or possibly surgery, where antigen antibody complexes form and then the reaction occurs to that. So it is a type 3 immune reaction. Which of the following conditions is this gram-positive organism most commonly linked to? A, orbital cellulitis, B, dacryocystitis, C, canaliculitis, or D, acute conjunctivitis. And the correct answer is canaliculitis. This is a pretty characteristic picture of the branching actinomyces israeli gram-positive organisms. They can be seen, or I've seen them around dacryliths, but they are commonly associated with canaliculitis and the little sulfur granules that come out. We also see them in sulfur granules in the tonsils at time of tonsillectomy. But other organisms can cause dacryocystitis, Staph aureus, Staph pneumo, and orbicellulitis is a different set of organisms as well. So the correct answer is canaliculitis. The angle illustrated here belongs to an 85-year-old woman who arrived from a nursing home with an acute red eye and elevated intraocular pressure. The most probable diagnosis is A, herpetic keratouveitis, B, angle closure glaucoma, C, pseudoexfoliation syndrome, or D, phacolytic glaucoma. And the correct answer is phacolytic glaucoma. Because what we're looking at here is the accumulation of these overly imbibed macrophages in the angle blocking egress through the trabecular meshwork into Schlemm's canal. Phacolytic glaucoma can present like acute angle closure glaucoma with a acute onset of a painful red eye. I've worked at St. Vincent's in my clinical practice in Ottawa, which is a chronic care hospital. In my 30 years of working there, I've seen at least 6 cases of this particular condition, all presenting like acute angle closure. But when you look, the chamber is deep and there is a hypermature cataract behind. Denatured lens protein, mature or hypermature lens material, incites a macrophage response in direct contradistinction to the native lens protein when disrupted, causing an immunologic reaction, a type 3 immunologic reaction. So this incites a macrophage response which blocks the anterior chamber angle and presents like angle closure, but is clearly an open angle blocked by macrophages. A 14-year-old girl presents with persistent unilateral conjunctivitis. Considering this presentation and the pathology shown, the most likely diagnosis is A, epidemic keratoconjunctivitis, B, herpetic conjunctivitis, C, molluscum contagiosum, or D, chlamydial conjunctivitis. And the correct answer is molluscum contagiosum. It's a pox virus-induced papular dermatosis, healthy children and young adults. Their associations for exams would be HIV and AIDS or atopic dermatitis. Clinically, it's a smooth, dome-shaped papule with central umbilication, often on the upper lid. When I've seen it clinically, I've seen it more on the upper lid, and causes a chronic unilateral follicular conjunctivitis. Why? Because the viral particles are basically shed right off the surface of the epidermis and right into the conjunctival sac. The characteristic red um, cytoplasmic inclusions are the pox virus particles, and they're called Henderson bodies. But that's molluscum. So the quiz is all the way to the residents in the Emerge Clinic with a unilateral follicular conjunctivitis. Make sure you check the eyelashes and the lids for the presence of a molluscum. This anterior chamber angle is seen in which of the following conditions? A, iris nevus syndrome. B, pseudoexfoliation. C, diabetic retinopathy. D, primary angle closure glaucoma. And the correct answer is iris nevus syndrome. What one sees, there are three subtypes: Cogan-Reese or iris nevus syndrome, essential iris atrophy, and Chandler syndrome. They're all different in their phenotypic presentation. Essential iris atrophy shows the chorectopia and polychoria. Chandler syndrome has minimal iris involvement, but maximum shows corneal edema and high IOP. And the iris nevus syndrome shows these knuckles of, entrapped iris stroma, which will give a pigmented appearance as in a nevus. But it's an abnormal basement membrane secreted by these metaplastic endothelial cells with epidermal cytokeratins, and it then closes the angle to get a secondary angle closure type glaucoma. This example of the essential iris atrophy with this membrane as it contracts, pulling holes in the peripheral iris. It can be seen in 50% can have this secondary angle closure type glaucoma. The corneal endothelium in these circumstances would stain positively with cytokeratins, as in PPMD, but the phenotype is entirely different between the two conditions. The next step in addressing this lesion discovered during an eyelid wedge resection is A, conduct map conjunctival biopsies. B, perform an exoneration. C, administer radiotherapy. Or D, ensure close clinical follow-up. And the correct answer is conduct map conjunctival biopsies, because this is sebaceous carcinoma. This is a very characteristic cytomorphology where you have these enlarged, somewhat vesicular, empty appearing nuclei with this very foamy or bubbly cytoplasm. Sebaceous carcinoma is more common slightly in men than women, 6th and 7th decade. Yellowish plaque or nodule. Never forget to look under the upper eyelid in a chronic conjunctivitis case. Don't forget the unilateral chronic blepharoconjunctivitis or masquerade syndrome. Also, this can present as an entropion because of the tumor scarring. The commonest site is the upper lid. And for residents going to exams, if you're looking at tumors that occur on the upper lid and you're given upper lid as a site, you think sebaceous carcinoma, in particular, as a highlight, and Merkel cell carcinoma occur on the upper eyelid. It's a disease of the meibomian glands more commonly than the glands of Zeiss or in the caruncle. The associations is Muratori syndrome, which is a subtype of hereditary non-polyposis colorectal cancer. But essentially, the association of Muratori with sebaceous carcinoma is so incredibly low that many pathologists don't do the workup for a Muratori syndrome, the DNA mismatch repair genes, because it's almost invariably negative. With sebaceous adenoma or sebaceoma, we'll talk a little bit later, that association is very high, but not with sebaceous carcinoma. Again, it is a ugly tumor if not caught early and completely resected. Which of the following genes shows abnormalities that serve as a marker for the condition depicted in this photo? A, TGFB1, B, B3GLCT, C, LOXL1, or D, PAX6. And the correct answer is LOXL1, because what we are looking at is the pseudoexfoliation syndrome, where you see this weakly PAS positive material like iron filings lining up on the lens capsule. We're all familiar with this. TGFB1 is in corneal dystrophies. PAX6 can be seen in anterior segment dysgenesis syndromes. This was an outlier. This child is susceptible to which of the following conditions? A, conjunctival melanoma, B, keratoconus, C, basal cell carcinoma, D, glaucoma. And the correct answer is glaucoma. What we are looking at are plexiform neurofibromas of the upper eyelid. This is a histopathologic picture of these irregularly oriented nerve bundles that form like a sack of worms. When they are involving the upper eyelids, especially bilateral, there is a high association with glaucoma. They are pretty much plexiform neurofibromas are pretty diagnostic of an F1. This lesion seen here is associated with which of the following conditions? A, xeroderma pigmentosa, B, Gorlin syndrome, C, Muratori syndrome, D, Cowden syndrome. And the correct answer is xeroderma pigmentosa. Gorlin syndrome, you're familiar with basal cell carcinomas at young ages. Muratori, we've already discussed with sebaceous adenomas, sebaciomas. Cowden syndrome is seen with multiple tricholomomas. All of these are variable tumor predisposition syndromes. So what is xeroderma pigmentosa? It is a hypersensitivity of the skin to UV radiation. It is an autosomal recessive condition due to a biallelic loss of one of 7 nucleotide excision repair genes. Characteristically, the malignancies present in youth include cutaneous squamous carcinoma, basal cell carcinoma, malignant melanoma, CNS, thyroid, hematologic, and gynecological cancers. Ocular involvement is seen in up to 90% of patients with xeroderma pigmentosa, with corneal vascularization and scarring and ocular surface squamous neoplasia. The positive staining seen here is diagnostic of which of the following conditions, and this is using Prussian blue. A, siderosis bulbi, B, hemochromatosis, C, amyloid deposition, D, Wilson's disease. And the correct answer is siderosis bulbi, which is an iron deposition disease caused by a retained iron intraocular foreign body. Bivalent iron ferrous is more toxic than trivalent for residents going to exams. The structures affected in siderosis include the iris dilator and sphincter, non-pigmented ciliary epithelium, the trabecular meshwork, why it's associated with glaucoma, lens epithelium, retina, and RPE. Characteristic feature would be the heterochromia because of involvement of the iris dilator and sphincter, the siderotic cataract due to lens epithelium, and the retina and RPE show pigmentary retinopathy kind of ERG changes. This is an example of the lens capsule. This is the lens epithelium, and this is the positive blue staining for iron in the retina. Hemosiderosis is the deposition of iron in tissues derived from red blood cells. And the etiologies can be intraocular hemorrhage. When massive and long-standing, it would give the same features as in siderosis. If it's associated with systemic disease, the common one is hemochromatosis, and that's accumulation of iron in the liver, particularly due to genetic abnormalities. But it has a different distribution of iron staining. Ciliary epithelium, sclera, and choroid. Most likely I've seen on an exams has been the association of hemochromatosis with scleral iron deposition, which is not what is seen in siderosis. And we're all familiar with Wilson's disease as the copper deposition disease, where it stains Descemet's membrane and the lens capsule, but not the lens epithelium. An 8-year-old girl presents with decreased vision and nystagmus. This is her iris. She is at risk for which of the following conditions? A, uveal melanoma, B, cutaneous melanoma, C, retinoblastoma, or D, squamous cell carcinoma. Excuse me. And the correct answer is squamous cell carcinoma, because what we're looking at here is an iris with a lack of pigment in oculocutaneous albinism. Oculocutaneous albinism is an autosomal recessive condition in 4 genes. There are 7 types. OCA1 is the most severe, which is tyrosinase negative. OCA2 is common in African populations. It can be syndromic, occurs with the Hermansky-Pudlak syndrome, seen mainly in Puerto Rico and Puerto Rican descent. It's a platelet storage pool deficiency associated with recurrent infections as well, and Shediac-Higashi, which is an immune deficiency syndrome associated with recurrent infections. In oculocutaneous albinism, there's decrease in the amount of melanin in each melanosome. So you can see that there is significant decrease in the pigment in the RP choroid and in the iris pigment epithelium. Ocular albinism is X-linked recessive, so-called Nettleship Falls, due to abnormality in the GPR143 gene. The number of melanosomes is decreased, and the size of the melanosomes is increased. They're macromelanosomes. So there's oculocutaneous and ocular. This finding is linked to which of the following conditions? A, giant cell arteritis, B, sarcoidosis, C, increased intracranial pressure, D, myopia. And the correct answer is myopia, because what we were looking at is myelinated retinal nerve fiber layer. You can see it extend past the uh, normal optic disc, extending onto the peripapillary retina. The normal myelination stops at the lamina cabrosa, but there can be oligodendroglial cells scattered extra embryonically into the retina in the nerve fiber layer, and they can produce myelin. Usually it is contiguous with the optic nerve. It's got a very white, feathery pattern to it. If large, it can cause scotoma. The classic associations are myopia, amblyopia, strabismus, and nystagmus. The biggest important thing for ophthalmologists to recognize early that it is not papilledema or a nerve fiber layer infarct. And one can see clearly that the blood vessels kind of streak through it and it can kind of go around it, but you can still see that this is not like a cotton wool spot, which would obliterate the vessels below it. This schematic of macular neovascularization is identified as which type of membrane? A, type 1, B, type 2, C, type 3, or D, type 4? And the correct answer is type 3. This is the types of neovascular membranes. Type 1 is the classic seen in AMD originating in the choroid, and it's between Brooks membrane and the sub-RPE space associated with basal-laminar and basal-linear things. This is the outer layer of Brooks membrane, the inner layer of Brooks membrane, and you can see these vascular channels here. Type 2 neovascular membrane originates in the choroid. The etiologies are classically ocular histoplasmosis, lacquer cracks, and chorioretinitis. It occurs in the subretinal space above the RPE. It's usually associated with more inflammation than the type 1. And then there is the one I just shown in the picture, type 3, formerly known as retinal angiomatous proliferation. It arises from the deep capillary plexus of the retina and grows towards the RPE. It is a feature of AMD. So the picture shown was type 3. There is the classic picture. Hard to find a microscopic image, though. This unilateral temporal artery biopsy is reported as non-specific chronic inflammatory change in the media, negative for giant cell arteritis, owing to the lack of giant cells in the biopsy. Your next step as treating ophthalmologist should be A, discontinue steroids, B, biopsy the other side, C, call the pathologist and ask for a review, D, do nothing and continue treatment. And the correct answer is call the pathologist and ask for a review. 50% of arteritis in giant cell contain no giant cells. So a poorly trained pathologist reading these could easily describe an active disease without calling it this because he didn't see a giant cell. So this just brought this to fore to stress that if you get a pathology result that doesn't make sense to the clinical picture you're looking at, or you have trouble even interpreting what they're saying, pathologists are fairly friendly people, and they would rather have a conversation with you now than a conversation with the lawyer from the CMPA after things go south and everybody's been sued. So, in a circumstance like this, it's important to review the pathology. And as I said, as a pathologist, busy days, things can happen. I'd rather be talking to somebody about something that I may have overlooked or not interpreted properly than have it come up later. And I would say that you could, as a reluctant person, a neuro-ophthalmologist, you've read the report. It says it's giant cell arteritis, even though they're calling the diagnosis negative, do nothing and continue to treat it. But that then stays on the record as a negative biopsy, and down the road, that could create problems when this is clearly a positive biopsy. Which of the following conditions is linked to this finding in the optic nerve? A, von Hippel-Lindau syndrome, B, Sturge-Weber syndrome, C, angioid streaks, D, neurofibromatosis. The answer is angioid streaks, because what we're looking at is optic nerve drusen, or optic disc. The calcific mass is formed anterior to the lamina cribrosa within the scleral ring. It's due to abnormal axon metabolism, usually associated with a very narrow optic canal at the disc, leading to mitochondrial calcification. The associations are angioid streaks and retinitis pigmentosa. Complications can be anterior ischemic optic neuropathy, peripapillary choroidal neovascular membranes, retinal vascular occlusions, visual field defects that can mimic glaucoma. And pathology, we see very nicely this aggregates of calcium anterior to the lamina cribrosa within the scleral ring. The lesion presented in a 5-year-old boy can be treated most effectively with which of the following options? A, vismodegib, B, cimetidine, C, azithromycin, D, acyclovir. And the correct answer is cimetidine. Vismodegib is used for basal cell carcinoma nevus syndrome. Azithromycin is used for a series of infections, non-viral, and acyclovir would be used for herpes virus types infections, CMV or herpes. This is associated with which of the following? HPV 6/11, B, CMV, C, HPV 16/18, or D, HPV 25/26. The correct answer is HPV 16 and 18. We are looking at a sessile conjunctival squamous cell papilloma, which has a significant association with the oncogenic HPV subtypes. 6/11 is benign, 25/26 is benign, and CMV is not associated with papilloma pathogenesis. The identification of the conjunctival lesion here is A, junctional nevus, B, compound nevus, C, stromal or subepithelial nevus, or D, malignant melanoma. The correct answer is B, compound nevus. Conjunctival nevi are neoplasms of the constituent melanocytes in the conjunctival epithelium. The normal maturation as the melanocytes travel from the neural crest into the epithelia of the body is they go to the epithelial basal layer where they reside, and after a while they undergo their genetic mutation that then makes this benign melanocyte into a neoplastic melanocyte, and then it starts to form contiguous groups along the basal layer of the epithelium, which is a junctional nevus seen in children. It then forms small nests, and these nests in the conjunctiva drag the surface epithelium down with them to form these classic cysts we see clinically. Here, very reassuring, these cystic lesions. And if I look here, you can see again these very classic cystic lesions. And they then also populate the stroma. 78% of conjunctival nevi are compound. The median age is 22. Clinically, bulbar surface caruncle, they're usually cystic. And then finally, in the maturation, they drop completely off the epithelium down into the substantia propria or subepithelial tissue, and they're stromal. The median age is 46, and you see the progression. Now, the importance of this particularly is that if you biopsy a pigmented lesion on a conjunctiva in a 65-year-old and you get a diagnosis of junctional nevus, that is clearly wrong. Junctional nevi do not occur in 65-year-olds. That is a conjunctival melanocytic interepithelial lesion with a propensity for malignant transformation. So that's why the diagnosis and the age of this becomes very important. Which of these immunostains would best determine the origin of the lesion seen located on the bulbar surface? A, SOX10, B, EMA, C, CD20, D, Ki67. And the correct answer is SOX10, because what we were looking at is conjunctival melanocytic intraepithelial lesion, melanoma in situ. One could see these irregular nests of melanocytes that extend basically full thickness, often very little pigment in it. The standard immunostains would involve possibly an EMA if one was suspecting a sebaceous carcinoma, because sebaceous carcinoma is EMA positive, whereas melanocytic lesion is EMA negative. CD20 is a lymphocytic marker, not going to help. Ki67 is a proliferative marker, which would be increased but is non-specific. The pagetoid intraepithelial spread of malignancy, illustrated here in melanoma in situ in the black circle, is also typical of which other type of malignancy in the ocular adnexa? A, basal cell carcinoma, B, adenoid cystic carcinoma, C, malignant lymphoma, or D, sebaceous carcinoma. And the correct answer is D, sebaceous carcinoma. Conjunctival melanoma is linked to which of the following genetic signatures? A, GNAQ, B, BRAF, C, FOXO1, D, PTCH1. The correct answer is BRAF, which is part of the MAP kinase pathway, which is the same genetic linkage seen in cutaneous melanomas. GNAQ is a marker of uveal melanomas or blue nevi. FOX1 we talked about in rhabdomyosarcoma. PTCH1, patch 1 is seen in the basal cell carcinoma syndrome, nevus syndrome, basal cell nevus syndrome, or Gorlin syndrome. So going further into melanoma of the conjunctiva, which gene mutation is linked to an increased likelihood of metastatic disease in conjunctival melanoma? A, BRAF, B, NF1, C, NRAS, D, GNA11. And the correct answer is NRAS, which again shows the same type of signature as in cutaneous melanomas and not like uveal melanomas. Excuse me. Conjunctival malignant melanoma occurs in three settings. 75% arise in primary acquired melanosis, the clinical term. Conjunctival melanocytic intraepithelial lesion, the pathological diagnostic term. 18% arise de novo, 7% arise in a pre-existent nevus. The risk of a nevus on the conjunctiva evolving into melanoma is about 1 in 300. The molecular studies, again, 30% are BRAF positive, important because then they are eligible for vemurafenib therapy, which is an anti-BRAF antibody treatment. NRAS shows the higher metastatic risk. Important to remember for residents and exams, cutaneous melanomas have a signature as conjunctival melanomas. Uveal melanomas are entirely different, which is why uveal melanomas metastasize to the liver hematogenously, whereas conjunctival melanomas metastasize to lymph nodes like cutaneous melanomas. This conjunctival lesion has recently been shown to respond to which of the following? A, tocilizumab, B, vismodegib, C, pembrolizumab, D, HPV vaccine. And the correct answer is D, HPV vaccine. This is squamous cell carcinoma in situ of the conjunctiva or conjunctival squamous intraepithelial neoplasia grade 3. And nice work done by Carol Karp in Florida was able to show that the HPV vaccine has shown the ability to cause some of these to melt away. And when we do evaluations of these immunohistochemically, we use the marker P16, which is a surrogate marker for the oncogenic subtypes of conjunctival squamous enteropathy and neoplasia. Tocilizumab is used in giant cell arteritis. Vismodegib is BCC. Pembrolizumab is an immune checkpoint inhibitor, not relevant to this. So ocular surface squamous neoplasia, remember it's due to increased UV light exposure seen in older adults. The oncogenic subtypes HPV 16/18, OSSN less than 50. I suggest less than 40 because we see in a number of places I work a lot of farmers, so to speak, out in the fields where they will develop these lesions and they are not HIV associated, but HIV is an association in young people. Cigarette smoking and xeroderma pigmentosa, gelatinous papillomas, and leukoplakic are the clinical subtypes. We call it conjunctival squamous enteropathy, the neoplasm, or CSIN, mild, moderate, severe carcinoma in situ. The excision is the most common curative. Topical chemotherapy can also help and can be used as well quite successfully. And then the HPV exam, the IM9 valent one, is the one that was used in the studies. Which immunostain is most suitable for characterizing this lesion that appears as a salmon patch? A, pancytokeratin, B, melon A, C, CD20, D, adipofillin. And the correct answer is CD20. The vast majority of ocular adnexal neoplasms, like 95%, are B-cell lymphomas, and CD20 is a pan B-cell marker. They are cytokeratin negative, they are not melanocytic, and adipofillin is a marker for sebaceous carcinoma, so it wouldn't be appropriate for this. What does this image depict? A, Homer Wright rosette, B, floret, C, Flexner-Wintersteiner rosette, or D, pseudo rosette? And the correct answer is Flexner-Wintersteiner rosette. Homer Wright rosette has a neuropill without a clear lumen. A floret is a collection of inner segments of the photoreceptors, the most differentiated. Pseudorosette is a collection of tumor cells around a blood vessel in retinoblastoma. All of these are retinoblastoma. Which statement about the lesion shown here is correct? There is a significant male predominance. B, that's A. B, it originates from the pigmented ciliary epithelium. C, 2/3 of cases are classified as the teratoid subtype. Or D, there is a systemic link to pleuropulmonary blastoma. And the correct answer is there is a systemic link to pleuropulmonary blastoma. Of course, we're talking about medulloepithelioma, which is a primary intraocular embryonal neuroepithelial tumor, second commonest malignant tumor in children, primary to the eye, retinoblastoma being the most common. 63% occur in young girls. It's unilateral and solitary circumscribed mass of the ciliary body, can also involve the retina and optic, arise from the retina or optic nerve. It's sheets and ribba-like structures of polarized neuroepithelial cells. There are two subtypes. 2/3 are non-teratoid, 1/3 are teratoid, and the teratoid have heterotopic elements such as cartilage. A small percentage are malignant, and that's when there is an overwhelming component of retinoblastoma-like cells. And 5% of patients have Dicer1 germline mutation, which is again a hereditary tumor diathesis. One of the most malignant is a mesenchymal pleuropulmonary blastoma that occurs in young children. Dicer is an RNA splice gene. So the association is that of a pleuropulmonary blastoma syndrome. This finding in the cornea is seen in which of the following conditions? A, atopic keratoconjunctivitis, B, keratoconus, C, neurofibromatosis, D, Peters anomaly. And the answer is keratoconus. Keratoconus is a bilateral non-inflammatory ectasion of the central or inferior central cornea. The association are Downs, atopic dermatitis, Marfan's, Leber's congenital amaurosis. There is a central or paracentral corneal thinning, seen up here. Focal discontinuities or fragmentation of Bowman's layer is characteristic. Apical anterior stromal fibrosis, which is often below these fragmentation of Bowman's layer, and then a Fleischer, which is an iron ring in the corneal epithelium. Which syndrome is suggested by this lesion? A, tuberous sclerosis, B, Down syndrome, C, neurofibromatosis type 1, D, Cogan-Reese syndrome. The correct answer is neurofibromatosis type 1. This is a Lich nodule, which is a small melanocytic hamartoma. Just wanted to contrast Lich nodules, which you see as these brown little spots here. More than two are felt to be pathognomonic early on for, or characteristic, sorry, for NF1. These are brushfield spots, which is this circumferential, whitish, small white nodules that have not been histopathologically characterized that I could find that are seen both in normal people, but are also typical of patients with Down syndrome. A 24-year-old female with scleral pigmentation is seen. This is the biopsy. Which type of melanoma poses a risk for her? A, cutaneous, B, uveal, C, conjunctival, or D, orbital? Correct answer is uveal. This is an episcleral melanocytosis. This just brings into the discussion of oculodermal melanocytosis, or the nevus of Oda. It's a proliferation of pigmented and dendritic melanocytes in the distribution of V1 and 2, most common in Asian ethnicities. 90% are unilateral. The patterns vary depending on which of the skin or the conjunctiva, episclera, or the uveal tract is involved. But importantly for exams, it's the uveal melanoma risk in Caucasians, because oculodermal melanocytosis is a proliferation of pigmented melanocytes which show a GNAQ mutation in the development of these proliferations. It's the same as in primary ciliary melanomas and CNS melanomas. There can also be orbital melanomas in nevus of Oda, but they are way less common than uveal melanomas. All of the following statements about this lesion are true except it predominantly occurs in the inferior quadrant in males. The calendar classification is unsuitable for prognosis. C, most of these lesions exhibit BRAF mutations. D, metastasis occurs in 5% of cases within 5 years. And of course, we're looking at an iris melanoma, so most of these lesions exhibit BRAF mutations is incorrect because this is a uveal melanoma. It would be GNAQ, GNA11, plus or minus loss of BAP1, etc. Risk factors are congenital ocular melanocytosis for melanoma of the iris, dysplastic nevus syndrome, or the BAP1 tumor predisposition syndrome. The genetic signature of uveal melanomas would be seen here. The calendar classification applies for the spindle cells and epithelioid, but it does not have prognostic significance as in the choroidal melanomas. They tend to have a much better prognosis with metastasis in only 5% of patients at 5 years. Risk factors for metastatic disease and death incur older age at presentation, increased thickness, and extraocular extension. Which of the following statements correctly relates to this lesion? Malignant transformation occurs in 20% of these. There is a slight preference for females. Visual field defects are rare. It is only observed at the optic nerve head. The correct answer is there is a slight preference for females. We're talking about optic nerve melanocytoma. It can occur in the iris and uveal tract where gender predilection is not seen, but when it is seen in the optic nerve, it is slightly more common in women. It's this dark black, jet black nevus that occurs usually infratemporal disc, more common in African Americans and Caucasians. The malignant risk is in Caucasians about 5%. The cell type associated with most unfavorable prognosis in uveal melanoma is A. spindle, B. epithelioid, C. plump polyhedral, or D. spindle B. The correct answer is epithelioid, which is this discohesive pattern to the epithelial-like looking cells, ergo epithelioid. In cases of uveal melanomas, which genetic mutations can also be found in the germline? A. BAP1, B. SF3B1, C. EIF1AX, or D. RPL5? The correct answer is BAP1. And there's a very famous BAP1 tumor predisposition syndrome that includes uveal melanomas, cutaneous melanomas, and other malignancies. PRAME, preferentially expressed antigen in melanoma, expression has been demonstrated to A, decrease metastatic risk in class 1 uveal melanoma, B, increase metastatic risk in class 2 uveal melanoma, C, increase metastatic risk in class 1 uveal melanoma, or D, have no effect on metastatic risk. And the correct answer is increased metastatic risk in class 1 uveal melanoma. If we look at this nice schematic of the molecular genetics of uveal melanomas, you have a driver mutation in the G-coupled protein receptor signaling pathways, GNA11 or GNAQ, in 90% of uveal melanomas. It takes the melanocyte benign to a neoplastic melanocyte. If the second genetic abnormality is a biallelic inactivation of BAP1 on chromosome 3, that automatically goes into class 2 melanoma. It is associated with loss of chromosome 3 and 8p or gain of 8q. That is a extremely high metastatic risk and poor prognosis. If the early melanocytic neoplasm undergoes an E1F1AX mutation, that is a low metastatic risk and a good prognosis. If it undergoes an SF3B1, this is inevitably associated with a PRAME mutation, and that shows a late intermediate metastatic risk 10 to 15 years down the road. That's a rough schematic of the genetics of uveal melanoma. The photo corresponds to an orange-yellow tumor in the fundus. What is the systemic association? A. von Hippel-Lindau, B. Wyburn-Mason, C. Sturge-Weber, and D tuberous sclerosis. Correct answer is Sturge-Weber. This is a choroidal hemangioma. It's a red or orange tumor in the postequatorial fundus, secondary retinal detachments. The diffuse type is seen in Sturge-Weber encephalofacial angiomatosis. Gives this the reddish-orange tomato ketchup fundus. Best way to observe this is contrasting it with the other eye because it is not always bilateral. And 75% of Sturge-Weber syndrome and choroidal hemangioma have glaucoma. The occurrence of this lesion in a 15-year-old should prompt consideration of which of the following? A. Gorlin syndrome, B. neurofibromatosis 1, C. Cowden syndrome, and D. Muratori syndrome. And the correct answer is basal cell carcinoma superficial type, so it's Gorlin syndrome. Gorlin syndrome is an autosomal dominant inherited neoplastic syndrome. It's due to germline mutation in the patched1 gene, which is a signaling in the hedgehog pathway, multiple basal cell carcinomas at young ages. It's important to know, especially for the residents, because it can be treated with a hedgehog pathway inhibitor, which called vismodegib, and there's another one as well that binds to smoothend, and it's been approved by the FDA for treatment of Gorlin syndrome and for locally advanced basal cell carcinomas. The histopathologic features observed in this upper eyelid tumor are linked to which of the following viruses? A human papillomavirus, B, a herpes virus, C, a retrovirus, D, a polyomavirus. And the correct answer is polyomavirus because this is Merkel cell carcinoma. Merkel cell or primary cutaneous neuroendocrine carcinoma occurs in older individuals, slightly more common in men, painless reddish purple nodular indurated plaque on the upper eyelids. The Merkel cell polyomavirus is positive in up to 85% of cases. It is a very malignant tumor with 33% occurring at least recurring once, 40% distant metastasis, and 33% overall mortality. So, which of the statements regarding the lacrimal gland tumor present here is incorrect? A, it has a bimodal age distribution. B, the most common presentation is inferomedial globe displacement. C, the preferred initial management when suspected is excisional biopsy to reduce risk of recurrence. D, definitive management is complete removal and radiotherapy. The correct answer is C. The preferred initial management when suspected is incisional biopsy, not excisional, because you want to know the diagnosis and plan your treatment. For pleomorphic adenoma, which is a benign tumor, it is excisional biopsy because the tendency for recurrence and progression to carcinoma ex pleomorphic adenoma dictates you want to take it all out on the first crack. So adenoid cystic carcinoma shows a bimodal age distribution, largest peak in the fifth decade, smaller peak in the first decade. Infromedial globe displacement, pain and paresthesia are the cardinal signs. The cribriform pattern is most common. Basaloid has the worst prognosis, and perineural invasion is characteristic. The overall survival rate is only 81%, and at 20 years, it's down to about 15%. A 38-year-old woman comes in for a routine examination during which asymmetric optic disc cupping is noted, leading to discovery of the tumor whose pathology is seen here. Which of the following statements regarding this tumor are accurate? A subset of these tumor arises in the setting of NF1. B, tumor growth may accelerate in pregnancy. C, most primary tumors are bilateral. D, the age of presentation in men is older than women. Diagnosis. Tumor growth may accelerate in pregnancy. Of course, we're talking about optic nerve sheath meningiomas. 92% arise from the intraorbital portion of the optic nerve. The classic triad is visual loss, optic atrophy, and optociliary shunts. Women are more common than men, may accelerate during pregnancy. The age of presentation is earlier in men. A small subset is associated with NF2. The majority are benign WHO grade 1, and the prognosis is good. Just about done. A 49-year-old woman presents with swelling of the right lacrimal gland, and the findings from the orbital biopsy are shown. Which statements regarding this lesion, which of the statement is incorrect? Elevated numbers of IgG4 positive plasma cells greater than 10 to 50 cells per high power field are pathognomonic of IgG4 related disease. The lacrimal gland is the most common site of the orbit of ocular disease, Orbital nerve involvement strongly suggests IgG4 related disease, and rituximab has been recommended as second line treatment in severe refractory or vision threatening disease. The incorrect answer is, of course, elevated numbers are pathognomonic. That is not true. IgG4 positive plasma cells can be seen in numerous inflammatory conditions. IgG4 related orbital disease, though, is a disease in the fourth to seventh decade, more common in men, associated with asthma and drug allergies. Proptosis, bilateral involvement, orbital nerve involvement, associated with autoimmune pancreatitis, hepatitis, sclerosing cholangitis. The fibrosis is focally storiform, not in the lacrimal gland. There's a characteristic lymphoplasmacytic infiltrate. Obstructive phlebitis, eosinophilic eccentric fibrosis are seen in the orbit, not lacrimal gland. Usually the IgG4 to IgG ratio is greater than 40%, and the absolute numbers in the lacrimal gland are 100, but none of that is pathognomonic. It needs to be taken into context with the whole. There's an increased risk of non-Hodgkin's lymphoma, and steroids are the mainstay of treatment, but rituximab has been successful in 93% of cases. So thank you for your attention. just to bring to the residents or anybody who's interested, I have put the most useful immunohistochemistry and ophthalmic pathology on a slide and molecular genetics and ophthalmic pathology. These would be good review for exams and trivia questions that tend to show up on those kind of exams. So I thank you for all of your attention. There's a little bit of time left. Um, so I'm happy to entertain any questions through Dr. Sharma.
That was
Dr.
fantastic.
Farmer, that was so masterful there. I think every ophthalmologist should be attending this lecture. I think he got 94, which is really good, but everybody should be mandatory thing because everything we see in medicine has a genetic and cytologic basis, and you review it so wonderfully.
Thank you. Yeah, it's amazing even in my 32-year career in anatomic pathology how basically genetics and molecular genetics, immunohistochemistry has revolutionized. I mean, I tell our young trainees that, it's the pathologist that directs what the oncologists give for treatment and what future drugs are going to work and whatever by the genetics and the immunohistochemistry we are able to do on tumors, for example. Um, but it really is revolutionized and will become only more personalized as medicine goes further.
Oh, Jim, could you put up your last two slides again? I think the
Mhm.
audience would like them. Yeah.
Yeah. I mean, I can't really go through them all. It's really, I guess, is I can also print them out, and for anybody who's interested, I can send it to them as well. But these are the ones, immunostains, immunostains are directed for an antigen to help us identify the tissue involved. These are the ones that we would most commonly use, and I try to, explain them. And then the molecular genetics to explain a little bit more about some of the pathways and some of the molecular genetic studies we would do on tumors that give us issues are all that I try to put it here.
So,
So I guess people could actually take pictures as
interrupted you. Were there any questions there?
I just
Someone
have
wanted to
one
look at the
question.
siderosis slides again.
well.
Yeah, Heba, is that you? Yeah,
Yes.
yeah.
Dr.
Okay.
Farmer, you mentioned that the uveal behaved more like skin, whereas
Sorry?
the uveal melanoma behaved more like a skin melanoma. They
No,
metastasized to the.
no, the uveal melanoma behaves um, different than cutaneous. Cutaneous goes to lymph nodes, uveal goes to liver.
Mm,
So the genetic signature of uveal melanoma, I'm sorry if it got confused, is completely different than the conjunctival melanoma and cutaneous melanoma.
okay.
We've always wondered why uveal melanoma doesn't characteristically go to lymph nodes, and the conjunctival melanoma always goes to lymph nodes. And clearly,
Understood.
it's the genetic predisposition. It was originally thought that maybe the uveal melanoma was more like a sarcoma profile, because sarcomas tend to go hematogenous metastasis before lymphatic metastasis, whereas carcinomas, um, cutaneous melanomas, whatever, they go to lymph nodes first.
Okay. And my other question was for the MIC-N, you showed like a very poorly differentiated. Was it a retinoblastoma
Yeah,
or a
it's
retinocytoma?
it's a retinoblastoma. A
Blastoma.
retinocytoma is technically it's a benign tumor. It's a tumor of maturing retinoblast precursors and florets. So a retinocytoma is a benign tumor. A
Mhm.
retinoblastoma is the malignant tumor. And there are
Yeah.
certain conditions where you see retinocytomas. They can occur spontaneously, they can occur post-treatment, they occur in family members of the people who've had retinoblastoma. But a retinocytoma is a benign tumor. The
Hmm.
tumor that I showed you, the MYC-N oncogene activated retinoblastoma, is a particularly like more poorly differentiated, aggressive retinoblastoma occurring in younger children.
Okay. Thank you.
So Jim, once again, like a most amazing lecture. Like you so much information in 2 hours, and it's a wonderful review. And I learned a lot, new things too. Um, yeah. David, did you have a question? It looks like your hand's up, David M.
Yeah. Hi. Thanks for the excellent talk, Dr. Farmer. I'm just wondering if you could pick one topic about the eye that an anatomic pathologist might want to know for the Royal College. What would it be?
For an anatomic pathology resident?
Yeah.
Well,
Hi.
I think that the ones you need to know from ophthalmic pathology, to be honest, is uveal melanoma, retinoblastoma, conjunctival melanoma, and sebaceous carcinoma.
Thank you very much.
And interestingly, when I wrote my pathology exam, we had to pick 5 of 7 short answers in 3 hours. And the very first question they put out of the 7 to pick, the first one was discuss uveal melanocytic lesions of the ocular adnexa. And there was a whole room going, oh no. And there was one guy going, yes. So if I'm looking at anatomic pathology residents, those are the ones I stress because they're the most, certainly retinoblastoma, uveal melanoma, that's what we deal with. But sebaceous carcinoma is going to mess up an anatomic pathologist.
Yeah, it sent chills down my spine hearing that was your first question, but I appreciate the heads up then.
Mhm.
Yeah, great. I mean, you had people from China, we had anatomic pathologists, and it's
Well,
really good, Jim. Yeah.
thank you very much. It's all your promotion
Yeah.
there. And so this was great. I'm happy to do it.
Okay.
Thank you.
Thank you
Okay.
so
Great.
much.
Great. Thank you so much. Yeah.
You're welcome. Good night,
Have
everybody.
a great night, everybody. Yeah.
Thanks. Bye-bye.